how can we help somebody recover from the trauma that they've experienced in their past so that they can learn to function in a society and in relationships in a way that is more appropriate, that doesn't stigmatize them for the things that they've been through.
Welcome to the Specialty Café, the podcast that helps you, medical trainees, find your perfect specialty. My name is Cameron Wong, and I am a current fourth-year medical student at Queen's University. I'm really excited to be producing this episode as a part of the rewind of the primary specialties, this time for psychiatry with a resident, Dr. Patricia Celan. And I'm really excited to chat with her about her specialty and her life as a resident. Hi, Patricia, and thanks so much for joining me on the podcast today.
Hi, thanks for having me. I'm Dr. Patricia Celan. I'm a psychiatry resident.
Nice to meet you. So I guess we'll start out with the basics. What is psychiatry?
Psychiatry is the branch of medicine that focuses on mental health, and we're looking at things like cognition and mood and behavior. And so the way that we help people in psychiatry is with a combination of things. So there's medication, there's also therapy, and there's also a biopsychosocial approach. So looking at every aspect of a person to help them improve their well-being.
Mm-hmm. There's a lot of aspects to psychiatry to master, as I'm sure you hinted to. The pharmacological part is quite a significant part that I think as a medical student I'm familiar with. I matched into internal medicine, so not psychiatry, but what I know psychiatry for is that there are a lot of medications to know. Mm-hmm. But then also alongside that, you mentioned are the non-pharmacological treatments, like, for example, all the different types of behavioral therapies, and then of course like the biopsychosocial model as you noted. So yeah, for sure a lot. In terms of the psychiatry residency, could you share a few more details about it? It's 5 years, is that right?
Yeah, it's a 5-year program, and then if people wish to do a subspecialty, there's child and adolescent psychiatry, there's geriatric psychiatry, forensic psychiatry. Those would be either an extra 2 years on top of the 5-year residency, or some people match into that earlier, and then they do half of that in their 5th year, so then it becomes a total of 6 years. And so in a standard 5-year psychiatry residency, the first year would be more of a foundational one where there can still be some non-psychiatric rotations that are still relevant. So there is some internal medicine, there's some family medicine, there's neurology in first year. And then, of course, there are some foundational psychiatry pieces. So emergency psychiatry, community psychiatry. And moving from first year into second year, it becomes more focused specifically on psychiatry. So there wouldn't be those off-service rotations anymore. So in second year, it becomes inpatient psychiatry for adults and outpatient psychiatry for adults. So going to clinics or being in the hospital. And then moving into third year, it becomes more specialized, more of a sample of like a subspecialty. So it's 6 months of child and adolescent psychiatry and 6 months of geriatric psychiatry. And then going from there, fourth year becomes more focused on things like addictions and consult liaison. And then there starts to be more electives. So fourth year and fifth year is where people get to decide to branch out and go into some electives.
In terms of the types of patients that you usually see within psychiatry, I know it's a little bit hard to nail it down because you just mentioned all those different subspecialties within psychiatry, but do you think you could talk me through like some of the different patients that you see on a daily basis?
I would say that it does depend on what type of rotation you're on. I find that in inpatient psychiatry for adults, there's a lot of psychosis. So lots of people having schizophrenia or different variations of the schizophrenia form types of psychosis, types of disorders. And that's what I've seen a lot on inpatients for adults. Now, inpatients for teens, child and adolescent, I've seen a lot more eating disorders, especially apparently it's been on the rise in the past few years. So and there would be more of kind of more bread and butter stuff like OCD and depression, and I have seen some psychosis in teens. but I would say that for inpatient psychiatry, my experience has been that there's been a lot of psychosis, some bipolar disorder, but in teens it becomes more of a wider variety. And then when it comes to outpatients, that's people who are able to function outside of the hospital. So they're what they have may be a little bit less severe, but they're still struggling. So in outpatients, I may see something like more anxiety disorders, people struggling with social anxiety, coming in for cognitive behavioral therapy for something like that, for example.
Yeah. Uh, Again, wide variety of patients that you see and care for, especially like within the inpatient versus the outpatient environments. As you mentioned, like in the inpatient environment, they're usually people who cannot care for themselves outside the hospital, whereas the outpatient, they can.
Mhm.
So yeah, you definitely get different paces of environments there, as I can imagine.
Yeah.
What convinced you to go into psychiatry in the first place?
So I might be an anomaly for this in that I've wanted to be a psychiatrist since I was a child. So I know that I've heard a lot of stories of people saying that they weren't too sure and then they experienced psychiatry in medical school and then they were like, okay, yeah, I like it. But for me, it was something where just as I think I first decided I wanted to be a psychiatrist when I was like 12. So I came across topics in psychiatry somehow. I'm not sure how. It's something, someone said something about disorders. And I remember looking it up and I found myself on this Wikipedia trap where I was just going from link to link and reading about all these different disorders. And I was super fascinated. And I think part of that comes from, so I know that there lots of people in medicine have really are lucky to have really privileged backgrounds. I unfortunately come from a background of abuse in my childhood home, and I think that set me up to wonder about why people behave the way they do, and to wonder about how to help people who are suffering from things like trauma. And so that I think is why I was so interested when I did start to read about mental health on the internet, and it became this passion for me where I would see something on TV that would be some kind of a hint towards psychiatry, and I'd think, I want to learn a little bit more about that. And one of my favorite movies when I was in my teens, I think it was Charlie Bartlett, which is about a teen boy who starts sort of acting like a psychiatrist to his classmates. And I was inspired and I thought I want to be that person who helps people like that in a legitimate way because he does it a little bit illegitimately. But it's been something that's been a passion and a calling for me since I was about 12.
Wow. So it's been a really long time coming for you for
Yeah.
sure. Wow. I find it very admirable that you have this like this background of abuse, but then used it as well. You responded to it and wanted to learn more about how I guess like human behavior can be,
Hmm.
what is behind like abnormal human behavior, and used it to help others as psychiatrists do. So
Hmm.
it's a very clear connection from what I can see. And I'm curious, like in the actual practice of psychiatry, now that you're a resident, are there certain aspects of your like everyday life or practice in residency that are most engaging for you and like really tell you like, yes, this is why I entered this field and this is why I want to be a psychiatrist?
I find that I'm more drawn towards people who have a trauma background because I can relate to that, and I know what it's like to be in that situation and to feel like things are so hopeless. I've seen some teens with trauma backgrounds, and my heart really went out to them, and it really felt like I want to help this person recover from this, get through this, and there's a light at the end of the tunnel where I know that they can have this they have so much potential, but it's hard to see that when you're in that tunnel. And so I feel the most connection to patients with trauma. And of course, a lot of patients in psychiatry have trauma, like about 90%, something like that, of patients in psychiatry, whether they have psychosis or anxiety disorders or something else, they there's a lot of trauma in psychiatry in general. So it is something that when I hear about it, I can connect with that patient a little bit more and it makes me want to help them more.
and I think by extension sounds like trauma-informed care is like a huge emphasis of yours, especially when approaching a new patient, continuing a revisited patient in psychiatry, a lens that you're always looking through to treat them. Is that right?
Yeah, I find that the more older way of looking at psychiatry is looking at people as some people are good or bad. You know, the idea of personality disorders is that some people are just bad. But I see all of that as through a trauma lens is a person behaves the way they do because of something that happened to them and a way that they learned to adapt. So I think that it's important to start shifting that paradigm from being a person that is disordered to the heterogeneity of trauma responses. And how can we help somebody recover from the trauma that they've experienced in their past so that they can learn to function in a society and in relationships in a way that is more appropriate, that doesn't stigmatize them for the things that they've been through.
Those are really great words. I think what I'm hearing from that is like recognizing that trauma is complex.
Hmm.
No patient's one experience is the same, and people are complex in their own way too. So I think by extension, it would be like only fair to like understand what a single person's like lived experience is, and to try and work with them to achieve like a therapeutic goal, like recognizing the context that they're in.
Yeah, I find that sometimes people look at a patient's behavior and they think, oh, this patient's being manipulative, this patient is doing this, and that's bad. And it's important to try to look at it through a lens of we're all just human beings who are trying our best to survive. And when we look at it in more of a survival kind of a way, then we can have a more compassionate lens to this person as this person's doing the best they can. And the best they can, it might not be very good right now, but they're motivated to do the best that they can, and we can help them to understand how they can do that in a way that is more effective.
Right, right. So with psychiatry, I think one of the phrases that stands out to me from my own psychiatry rotation was the saying that in contrast to other specialties, the physical exam in psychiatry is a conversation. Your toolbox are the words that you use to understand what is going on in someone's life, and to understand what they're hoping for, what they need. And so I think like by extension, I really thought of all psychiatrists as really great conversationalists. There's so much intention behind like your words, for example. I think they're all very well placed. I really understand everything that you're saying, and it comes off as natural. In psychiatry, are there elements that you feel like didn't come as naturally to you, or might have surprised you as you went through your residency training?
Well, when I was a teen, I was interested in the medications for sure, but when I actually got into medical training, I found that I was more interested in the therapy and in the conversation part, and the medications just didn't stick so well. So that's been something that for me personally has been harder to learn. So I went straight from a psychology undergrad to medical school to psychiatry residency, and I didn't do anything in between. Like some people have some more of a sciency medical background, some more pharmacology that they do, and I didn't do that. So for me, it was more that um, I love therapy and I really can connect with that. And the medications are a lot more rote learning. Now, that being said, that's me. I know that there are lots of people who are fantastic at learning the medications and it comes easily to them. And for them, they don't like the therapy aspect so much. So it's kind of like you can do whatever speaks to you more in psychiatry, depending on what kind of psychiatrist you want to be.
That makes a lot of sense. And certainly I've seen in like my own psychiatry rotation that there is a like heterogeneity of psychiatrists who rely more on medications because that's something they're more comfortable with, and other psychiatrists who put forward, such as you, the non-pharmacologic and like behavioral therapy aspect of things, like using conversation as a tool to understand and also to heal. And so, yeah, that definitely rings true. I'm someone who tends to like medications more just because
The internal medicine.
of course, yeah. But I can also very much appreciate like the importance of like conversation in medicine and understanding in that way. It's very, very important. Yeah. In terms of maybe the more challenging aspects of psychiatry, what have you kind of noticed as yeah, like what challenges have you noticed going through residency with like aspects of psychiatry that you might have not expected to be as difficult?
I've come across systemic limitations that have been frustrating to deal with. So, for example, I can recall one case where we were working with a teenager who was very clearly suffering from abuse in the home. And the team made a decision to call Child Protective Services. And when we did, and I was the main person speaking, but the whole team was there with me, uh, they told us that they had already done an investigation on that home and they found that it was fine and that the child was embellishing things and there was no issue whatsoever. And I know as a child of abuse what it's like to not be believed and what it's like to have parents who can put on a good show when there's somebody that they need to put on a good show for, but what can actually happen behind closed doors. So that has been frustrating, realizing that we do work in these systemic limitations where it's hard to get that kind of help for children. And you see that this person is going to continue to have eating disorder problems or anxiety problems because they're trauma related. And then so I had to, in that case, advocate and say, I understand that you've done an investigation, but we are seeing things that make us convinced that there is more to the story, and we'd ask you to do that investigation again. And luckily, my staff was with me at that time, and so he was able to back me up, and he applauded me for my advocacy. But I know that that's something where we have to make sure that we have a backbone because the system could very easily discourage us from giving our patients all the help that they need. And there's also systemic limitations around things like housing. You know, like patients can sometimes end up being admitted for longer than they should be because we have nowhere to discharge them to. And there's limitations around getting people connected with therapy supports. So there's all these limitations that you look at the system and you think our patients could do so much better if they had more of a safety net in every aspect of care.
Right. Yeah. If I was your preceptor, like making or supervising you while you advocated for that patient, I think I'd also applaud you.
Thank you.
It's yeah, it's a really great catch, and I think what I like get from that story is that although you as a physician might be trying your best to like really see through to like a patient who has a history of abuse and has a more complex history than like meets the eye, not everyone in the system does, and that is reflected in like the resistance that you face
Mhm.
in order to provide them with the best care. So like really glad to hear that there's doctors out you that are fighting the good fight essentially to make
Thanks.
sure that the patients get the best care as possible. And for sure, I would say like on internal medicine as well, there's definitely like the housing shortage, for example, affects patients in hospital and the inability to ensure that patients have like a safe discharge and a safe place to call home. Otherwise, they end up kind of having the hospital as like their only safe housing at the point. At that point, yeah,
Mhm.
for sure.
Yeah, another similar challenge that I've run into is patients coming into the emerge and pretending that they have mental health problems when they actually just are looking for housing. And I've been in that awful situation of having to confront and say, we can't admit you, and I'm sorry that we don't function as a hotel, and patients just dropping the act and saying, I just don't have anywhere to sleep tonight. And it's heartbreaking, and it puts it that's not what I signed up for, to be in this situation of deciding whether or not somebody gets a place to stay tonight. So that's something where, again, the wider system, we need to have more housing options for people.
You signed up for this career to help people like and use your own background to like really like propel you forward for that, not to be a gatekeeper of beds, really. Yeah.
Exactly, yeah.
Yeah, that's another realization that I think I started to gain when I started on my rotations too, just realizing that the world is so much more than medications and like the physiology and things that you learn well in like the first parts of medical school, but then you get into the hospital and realize that people are complex and so are the systems as
Mhm.
well. So yeah, very, very true. Um, I about your background and like kind of the other interests that you have. I'm aware that you do some other things on the side aside from just being a psychiatry, or I shouldn't say just being a psychiatry resident, but you're also involved in pageantry. You have a passion for arts. What has like balancing all of those things like has it been possible during residency? And like if it has, what has it taught you about like prioritizing things in your life?
I think balancing everything has come out to be a bit of a challenge where I have suffered through burnout a few times, and that's something where I've learned that it's important to set boundaries between my interests and my work, and to make sure that I have enough time for self-care. But it's been worthwhile for me because in my first year of residency, I didn't do pretty much any activities whatsoever, because I moved from one province to another, and where I moved to, there weren't really all those activities that I was very involved in previously. So all I had was residency in my first year. And I got very burned out and I became very unhappy. And adding other things to my life made it so that I could have more of an identity as a human being, not just a psychiatry resident. And that's, I think, an important balance to have just for the human psyche. Like, none of us are just doctors. We are people in all sorts of other senses of the word, and that's important so that that balance helps us to stay to function, to stay well, and to have perspective. So when things don't go well in our jobs within psychiatry or any other types of medicine, we have other aspects of our identity to rely on, to fall back on. So it's not just being a doctor.
I appreciate you being like honest about like your like mental state as you went through like the first parts of residency, struggling to find that balance, not being happy, and then realizing that you needed like more like humanizing aspects in your life aside from being a doctor all the time, which is like it happens a lot in residency for sure.
Mhm.
It's a very intense part of training, but I'm glad that you were able to kind of like add those things back in, things that I'm sure you've been doing for quite a long time, things
Mhm.
that make you happy, make you feel restored, make you use both sides of your
Yes,
brain.
absolutely. Yeah.
Yeah.
Having those creative parts to my life definitely make my life more enriched and more fulfilling.
And I think in turn, you probably deliver better care to your patients.
Hmm.
Being able to listen more, being able to relate more to them on a daily basis because you feel more full as a human.
Yeah,
Right.
absolutely. Yeah.
Yeah. Yeah. Very good to hear. Well, I. I've been really glad to chat with you about what it means to be a psychiatry resident and to go through it's like a really interesting residency to care for people of like all age ranges, you could say, and in a really meaningful capacity. To kind of wrap up the podcast, I was wondering if you can think of a piece of advice that you would give maybe your past self. It could be yourself at the start of medical school, maybe at the start of residency, any part of your past self, having known what you know now, um, to kind of guide you about what it means to go through medical training and be a physician.
Ooh, yeah. Something I would say to my past self is that it's important to create a community with your colleagues and to also create a community outside of work too, because sometimes the community within medicine may not work out as you hope it will. And it's important as a human being just to have people. Like, no man is an island, kind of a phrase. I found that the years when I felt more isolated, I was not doing so well. And the years where I had more of a support system in my life, I was doing a lot better. And so I would tell my past self, find a community and enrich that community and stay connected with people, because that, I think, is the one thing where um, I have done better when I have been well connected.
I'm glad to hear that. In medicine, I would say a field that puts often like accolades and the like the maybe prestige of a program like quite high as alongside other academic titles. It's sometimes easy to forget that like it takes a village to raise a resident in a way,
Mhm.
and in a way like hopefully you can choose your village in that same way,
Mhm.
to be the kinds of people that would encourage you to be the best doctor possible, and to support you when things are hard, to cheer for you when things go well.
Mhm.
Yeah, yeah, for sure. It's really great advice. I'm glad to
Yeah,
hear
it's
that.
important to have a support system
Yeah,
for sure.
for sure. Well, I'm really glad that I got the chance to chat with you,
I'm
Patricia.
glad I got the chance to talk with you too.
Thanks so much for tuning into this episode with Dr. Patricia Celan, an excellent psychiatry resident, who chatted about the wonders of psychiatry. And I'm really, really glad that I learned more about what it means to find balance in a profession, use and to use your background in order to understand patients better, to really help them better. Very inspiring. So yeah, if you are a resident in a Royal College affiliated specialty, remember to join as a resident affiliate member because it is free. And we'll see you at one of the next episodes of the Rewind on the primary specialties. I'm very excited to see you next time. This is Cameron Wong with the Specialty Café, and thank you very much.